Okay, so a number of projects that I'm working on try to open this black box by looking at the effects of different shocks and interventions very early in life on sort of intermediate outcomes. So child health and development, and then trying to trace out the full path of effects from birth through childhood into adult outcomes, and also thinking about channels. Okay, so what types of interventions do I have in mind? So if we think of the child human capital production function, we can think of broadly two types of inputs that parents can devote to their children, which can possibly affect their human capital development. And so, some of those inputs would be, we can think of them as material resources, and we can also think of parental time as a potentially important input that goes into the child human capital production function. So in different projects, I'm looking at different interventions that affect either material resources or parental time, again, immediately after birth or even during pregnancy. Today, I'm going to be focusing on a public transfer, which essentially gives a bunch of money to parents right after they have a baby. So I'm going to be looking at the effect of an income shock right at the time of birth on child development. So broadly, I'm interested in child development in different dimensions. So living conditions, health outcomes, and also cognitive and non-cognitive development. Today, I'm going to be focusing on health outcomes. So I'm going to be asking the question, does giving money to parents when they have a baby, does this help their children in terms of health? Okay, so that's kind of my introduction. So I contribute to this fetal origins literature. In particular, a recent survey calls this black box that I showed you the missing middle, in the sense that we don't have a lot of evidence for what goes on in between. I'm interested in particular I'm interested in interventions that can be affected by public policy. And today I'll be focusing on interventions that affect household material resources and income shock at birth. Now, in terms of previous evidence, of course, there's a large number of papers looking at the effect of cash transfers on health and school outcomes for children. In particular, in the development literature, there's all these papers looking at conditional cash transfers. Those are very different types of papers, but of course they're related. They're looking at contemporaneous effects of if you give money to poor families, conditional on you taking your child to the doctor, families tend to, yes, take their child to the doctor. So those are kind of contemporaneous effects of conditional cash transfers to poor families. And there's also a couple of recent papers for the US where they look at what happens when you give pregnant women a transfer, say food stamps or EITC money, what happens to their children in the long term. So looking at kind of adult outcomes of, so that also fits into this fetal origins, so a very early shock, long-term effects. But there's no paper doing, as far as I know, doing what I'm doing, which is a shock at birth on child outcomes using a well-identified natural experiment and administrative data on health outcomes. Of course, what I do is also related to the literature looking at how the business cycle relates to health, adult health or health at birth, and there's also a few recent papers on child health. That's a different literature. That's not so much identification driven, that's just correlating kind of the cycle with health outcomes and then trying to think of plausible mechanisms. It's of course related. They mostly focus on mortality or health at birth. And there's a number of recent papers looking at the effect of other types of income shocks on child health. There's one paper looking at the effect of winning the lottery in Sweden on child health outcomes, so that's of course also related to what I'm doing. Okay, so what do I do? What I do is I exploit a natural experiment with Spanish data combined with administrative data on child health. The natural experiment is the introduction of baby bonus, of child benefit in 2007. This was money given to mothers immediately after birth, and I'm going to be looking at health effects for now at ages 0 to 5. But the idea is to keep looking at these children as they age. My identification strategy is going to be a regression discontinuity design based on date of birth because of the way that the benefit was introduced. This is appropriate, as I'll show you in a second. And then in terms of outcomes, I'll start by looking at health at birth using birth certificate data. I'll show you these children are on average identical in terms of control versus treated group at birth. Then I'm going to look at extreme health outcomes, child mortality from their death certificates. I anticipate I won't find anything on child mortality, as you might have expected. And then my main outcomes are going to be essentially hospitalization rates. So I'm going to be looking at how much these children stay in the hospital over time with hospital register data by age and by diagnosis. And then once I show you my results, I'll try to say something about channels by using survey data using data from a range of different surveys. Okay, so more details on the natural experiment. So as those of you living in Spain may remember, of course this is 10 years ago, so on July 3rd, 2007, the Spanish president announced, so it was a kind of a surprise announcement, that all children born from that date on would receive a new benefit, a one-time 2,500 euro benefit, so that would be paid to the mother right after birth. So this is an important amount of money for Spain in 2007. This is almost 5 times the monthly minimum wage for a full-time worker and more than twice median monthly earnings for employed women, so several months of salary. It was universal, so all children born after the announcement date were eligible, with the only exception of mothers with less than 2 years of legal residence in Spain. And the explicit goals were to help families cope with the extra expenditures associated with a new child and encouraging fertility. Okay, in terms of take-up, essentially you can think of it as full take-up. I will look at the number of children born in Spain in 2008 and the number of benefits paid. It's about 95% of children receive the subsidy, and the 5% difference is probably the recent immigrants. The total cost was about 1,200 million euros per year. And this benefit, by the way, was canceled in 2011.
And then after March 2008, right? March or April, it's not a surprise anymore.
I'm only going to be looking right at the threshold, so for families who were surprised. Okay, so what I had in mind when I started the project was, so what are the channels via which an income shock in the household at birth can affect child outcomes, health and development. There's this literature that in sociology and also in economics where they address this issue of children from richer families do better than children from poorer families, and the standard channels that people have proposed are, first of all, the resources channel. So families that have a higher income, they can buy stuff that is good for the children, so better nutrition, better living conditions, so housing, stuff that you can buy with money. But also there's other channels. So there's the time allocation channel. So richer families perhaps can, perhaps parental labor supply is different, and perhaps if richer families, for example, the mothers work more or less, this could be beneficial for the children. And finally, there's what people call the family process channel, basically meaning that if you have higher income, this reduces parental stress, and maybe it reduces conflict in the household, and maybe emotionally the environment is better, and this results in better outcomes for the children. So ideally, I would want to explore which of these channels is at work in generating any potential health effect on the children. Okay. So the methodology is fairly straightforward. It's going to be, like I said, a regression discontinuity design. I'm going to be focusing on children born very close to the threshold. In the end, the benefit was paid to all children born on or after July 1st, 2007. So I'm just going to be comparing the health outcomes over time of children born a few days before July 1st and a few days after. So, the outcome is going to be a health outcome for child I born on date D. Post is an indicator for the child being born on or after July 1st, 2007. And then my running variable is going to be date of birth. And I can control for stuff if I want to. Okay, the main data sources. For my main health variable, I'm going to use the hospital morbidity surveys, which is basically the universe of all overnight hospitalizations in Spain. And then I'm also going to use birth certificate data and death certificate data, so population level data for these children. Okay, so before I show you the results, I need to convince you that the regression discontinuity design approach is valid. So there's two sets of validity checks that I'm going to be showing you. First, I want to convince you that so this was in fact unanticipated. It was a surprise. So families could not adjust in terms of, oh, I know this benefit is going to be introduced on July 1st. Let me delay a little bit the birth, or let me, I don't know, fake the date on the birth certificates so I can get the benefit. If that was the case, then we would see bunching in number of births at the threshold. In particular, we would see more births right after compared with right before the benefit introduction. We can check this with birth certificate data very easily. This is daily number of births by date, the exact date. 0 is July 1st, 2007. And this is, up to 50 days before, 50 days after. The variation that you see here, the noise, is because there's fewer births, considerably fewer births on Sundays and Saturdays than on weekdays. So if we aggregate this by week, this is weekly number of births. Still you see that there's nothing special going on right around this date. You do see a little bit of seasonality here by week, but I'm going to be focusing really on days very, very close to the threshold, so that's not gonna be a big problem. Okay, so I find no bunching in number of births at the threshold. Of course, this is confirmed with regression analysis. The second check that you want to see is, I want the families and the treatment and control groups, so children born right before and right after the benefit introduction, I want them to look exactly the same on average in terms of family characteristics, health at birth, everything that I can observe. Luckily, with the birth certificate data, we know a lot about these families. We know, everything, so health at birth, and we also know, parents' education, parents' ages, where they come from, and so on. And I can show that, in fact, family and newborn characteristics are smooth across the threshold. So just to give you one example, this is the fraction of babies with low birth weight. So this is weight below 2.5 kilos at birth. Again, there's a lot of noise with the daily data. This is the weekly data. And again, you see no significant jump in health at birth around the threshold or family characteristics.
Do you know if this is the first child?
Yeah, we know that.
This is always the first.
No, I include all, yeah. So I can also show balance and covariance in terms of parity, yeah.
Is the line that you're showing there, will they come up from the regression, the regression?
No, this is with no controls, just fitting a straight line here in the graph. Yes, of course, yes. But my regressions are not going to include this many weeks. It's going to be much more centered around the threshold. Okay, so health effects. I told you today I'm going to focus on health effects. My main outcome is going to be overnight hospitalization rates by age 5. So I just calculate from the hospital morbidity survey. So this is going to be using date of birth is going to be my running variable. So by date of birth, I know how many times children born on July 1st have stayed in the hospital at different ages and for different diagnoses. And I'm going to calculate hospitalization rates by dividing the hospital stays by the number of children born on a given day. And then, of course, I can also look at mortality rates. Again, I won't find anything on mortality rates.
But how is this in the survey? They ask parents how long the children have been in hospital?
So this is hospital records.
Okay.
Yeah, so you know the date when they were checked in and the date when they left. And you know the date of birth.
Can I ask if you mean by hospital stays is the number of hospitalizations or the number of days, the total number of days?
So here what I'm doing is I'm just using whether or not you stayed overnight. So a hospital stay will be counted as just one stay regardless of the duration, but I also observe the duration. So I could do something with the duration. Yeah.
Do you control for trends? Do you have information about trends? Because typically, in that case, there are
Yeah.
get much more money, but those are also the kids that are potentially at worse.
Yeah, so what I check is that the fraction of twins is no different in the treated versus controlled children. So there's no, and then but in the hospital data, I don't know if a child was hospitalized. I don't know if this child has a twin or not. So I cannot calculate the heterogeneous effects for twins versus singletons.
Why do you focus on 20 days? I mean, given that gestation's 9 months, you could go quite far back.
20 days? No, I don't focus on 20 days. 20
20
weeks.
20 weeks, right. Okay.
But in the regression, so I'll try different
Right,
different
but
windows.
You could still go further back.
You mean
I mean, the
without having to
gestation's
worry
yeah,
about
surprise, yeah, they're not
I see.
9 months before. But anyway, that may be a robustness thing.
Okay, no, but yeah, so I can play with the window, yeah. Okay, so this is my descriptive statistics for my main outcome variable. So the sample here includes all children born within 56 days. Why 56 days? Well, it's, I can change this. It doesn't. I'm going to show you different windows. So children born within 56 days before after June 30th, 2007. An observation is a day. So here I'm aggregating by date of birth, and mortality rates are per 1,000 births. So yeah, I guess the main number to look at here is this 0.6. So this is the hospitalization rate at ages 0 to 5 for all the children in my sample. So what this means is that so there are 60 hospital stays per 100 children born at ages 0 to 5. This includes, so it could be the same child hospitalized multiple times or different children hospitalized once. Okay, and then the most common diagnoses are perinatal conditions, so things that happen immediately after birth, respiratory disease, and infections. And then here I break it down by age. The age breakdown here is just, I keep the kind of overall hospitalization rate constant, so it's ages 0 to 1 month, 2 to 23, and 2 to 5 years, but I can also look at different age ranges. And these are the mortality rates.
I'm struggling with the first variable, so that should be like isn't that the number of hospital
Stays per child, you want, yeah.
It would be like, then the maximum has to be above 1, so.
No, because this is calculated by date of birth. So it's number of hospital stays over number of children born in each date of birth. So in any given day out of these 56 or 112 days that I'm including, the maximum hospitalization rate was 0.7. So there's one date where the hospitalization rate for those children who were born on that date was 0.7. But it's not individual children. I think that's what you're struggling with. It's not individual children, it's dates. Okay, so let me jump straight to my main result. So I'm going to show you different windows around the threshold. So this is, so the number of observations here is going to be number of days. So from 14 days, so these are children born really 1 week before, 1 week after the benefit introduction. And then I increase from 1 week to 2 weeks, 3 weeks, 4 weeks, and 8 weeks. Okay? I'm always controlling for day of the week because we saw that there's a lot of things going on for different days of the, so if you were born on a Sunday versus a Monday, things could be different. And then I also include linear trend or quadratic trend. I can play with that. Okay, so first the hospitalization rate for ages 0 to 5, so overall effects. So what I find here is that children who received the benefit were significantly more likely to spend a night in the hospital at ages 0 to 5. These effects are precisely estimated and the magnitudes are not small. If you remember, the average hospitalization rate was 0.6, so this is like a 10% effect. So this was not the sign that I was expecting. Yeah, so, okay, now I think I wanted to show you a figure now. Oh yeah, so this is the figure. This is, again, this is not the same specification as the regression. So the linear fit is not the same one I'm showing in the table, but for you to get an idea. So this is week of birth. This is number of hospital stays. So this is not even the rate, just the number. So it's much more kind of noise. But you do see, that if we compare the week right before, or the weeks right before and the weeks right after, the number of hospitalizations does change quite a lot. Okay, now by age. It would be very strange if I found anything right after birth, because the benefit was not paid. So first of all, it wasn't expected, and second of all, it took a couple of months. So I think the actual payment started in November. So these children were born in July. The families actually got the money in November, even though they knew they would get the money in July. But anyways, before age 1 month, I find 0 effects. But then after that, these positive significant effects show up, and they seem to be persistent up to, or at least still present after age 2, which is, surprising. So let me show you. Right, so that's what I'm going to be doing with as much time as I have. So this is ages 2 to 5. But this is, okay, so this is, I wanted to show you this. So this is, I tried to break down age a little bit more. So I see nothing immediately after birth. And then, so the kind of the larger significant effect is at age 1. And then after age 1, it goes down, and it's not significantly different from 0 by ages 3 and 4. So any channels would have to be consistent with the story of effects that would emerge after a few months. Okay, so first of all, you would want to see placebo checks. Is it just something that happens every year, that the children born in July are somehow less healthy than children born in June? So I performed the same exercise for children born around July 1st of 2006 and 2008, and I do not find any significant difference in hospitalization rates for these 2 other years. So then I do have to come up with some story for okay. So then let's check by diagnosis. First thing for diagnosis is, even though the most common cause for hospitalization is perinatal conditions, so conditions that originate immediately after birth, I do not find an increase in hospitalizations for those types of conditions. The largest effects are found for respiratory disease, infections, and other factors, which is kind of one category where they put all those hospitalizations that are not really associated with a medical diagnosis, but they include hospital stays for observation, testing, suspected disease, and so on. So these are not real medical diagnoses. I don't want to spend too much time on this table, but this is the effect on hospital stays by diagnosis. So this is the effect on all hospital stays, and then if we break it by diagnosis, no effect on perinatal conditions. The effect shows up in respiratory disease, infectious disease, nothing on digestive or injuries, which are also 2 kind of large categories, but we don't see an effect there. And this other factors category, we do see an important effect there. So, yeah. Okay, I do not find any effect on child mortality. I look at child mortality by 1 month, by 1 year, and by 5 years, and there's nothing, I wouldn't have expected an effect there. So no effect on child mortality. Now you're probably thinking, you would want to look at heterogeneity in the effect by household income. We do not observe household income in the hospital data, so the only thing that I could think of was to stratify by income in the province. So I run the same analysis separately for provinces with income per capita below the median or above the median, and it turns out that the positive effect on hospital stays is larger and more precisely estimated in the lower income regions. So again, I would have expected, the opposite sign of the effect in poorer regions. That's not what's going on, so that's again not what I expected. Okay, so channels. All my standard channels that I had in mind at the beginning are not going to work here, because all these channels would suggest that the income shock should make children better in terms of health. So parents have more resources that they spend on better nutrition or housing conditions or whatever. Time allocation, perhaps moms can stay home for longer, but that could lead to more breastfeeding, better health. And parents could be less stressed, but then that would again be good for child health. So I had to try to come up with potential channels driving the negative effect. So far, I've focused on 3, but if you have more ideas, I'll be happy to consider them. The 3 channels that I've considered for the negative effects are the following. The first one is perhaps the parents spend the extra money on unhealthy or risky behaviors, which could have affected the children negatively. Perhaps they spend it on smoking or drinking or, traveling or gambling, okay? The second potential channel could be, what if parents, because they have this extra money, they now decided to have another child immediately, and then perhaps having another sibling right away could have had negative effects on the previous child. And then the third channel could be potentially, perhaps there's higher utilization of medical services without an associated worsening in health conditions. Perhaps parents now are buying private health insurance and using private hospital services. Okay, so another thing is, can I really test for these channels? Some of them I can, others not so well. So I'm going to show you some tests for each of these channels, both these and these.
So the last one is consistent with the second order result that you found, right?
The utilization.
Will be precisely positive, yeah? So more significantly positive. So the last one.
This one?
So the last channel also explains why in poorer families it's more clearly positive, no?
Really? Okay. Why would that be?
Because the increasing money makes you more access, makes access to health services.
You mean the access to private?
Yes. Well, if it's private, maybe rooms
Okay.
better, or maybe a
So,
hotel.
if you know of any way in which I could test for this, because I don't know how to, I haven't found a good way other than expenditure surveys or the National Health Survey. I would like to have better quality data on private insurance, which I, yeah.
One question.
Yep.
The hospitalizations were mainly in public hospitals or private ones?
The hospital morbidity survey does not tell you not only the identity of the hospital, but not even whether it's public or private. I think I should really try harder to get at least whether it's public or private.
Because if it's private, they
Yeah.
more or less make sense, no, the results?
Yeah. So I should really try and get this information.
I'm thinking about the alternative econometric way to model your key-dependent variable, which is so I think you can get your normalization, but to me, like the number of stays is could be like a count variable. So is the distribution quite symmetric, or is it heavily skewed? So if you use Poisson models,
I've tried just the number of stays, but not with Poisson, just with OLS.
But if it's highly skewed, then that might make a difference to
Okay.
the results. So maybe your significant effect becomes insignificant.
Okay.
Yeah.
It would be easier to sell with a zero effect than with a positive effect.
Maybe,
Okay.
But you can check that easily by just checking.
Yeah, that's easy to do because I do have just the count. So, but I haven't tried the Poisson. So, thanks. Okay, so the resources channel. So how did families spend this money? Did they spend it on things that could help or hurt children? I analyzed the effect on household expenditure patterns with the household budget survey, and I find that the families who received the survey, I don't really find a significant increase in either total expenditures the first year after birth or child-specific expenditures, other than one category, which is childcare expenditure. So families who received the survey spent less on childcare during the first year of the child's life. So it looks like the children who received the benefit took longer to go to daycare. Longer. That's consistent with the time allocation channel, where I do find that moms who received the benefits stayed home a little longer. So I analyzed effects on parental labor supply with labor force survey and Social Security data. And what I find is that eligible mothers took a bit longer to go back to work after birth. This disappears by, like after a year, there's no effect, but they do take a little bit longer to go back. I also find from the National Health Survey data some evidence of a higher incidence of extended breastfeeding. Almost nobody breastfeeds for more than 4 months in normal times. The moms who receive the benefit, it looks like a number of them breastfed a little longer. Again, moms going back to work a bit later and breastfeeding a bit longer would suggest positive health effects. So this doesn't help me.
But it also means that they can stay at the hospital.
Yes, that's correct. Yep.
Sorry,
It also means that they can stay at the hospital.
Yeah. Yeah.
You showed us that when the kid is 1 year old is when the higher hospitalizations, and it might be online with this. When mom won't go to work, they go to the nursery, and then at the beginning they might get more disease or something.
So this is something I have to do, like to try to do more in terms of comparing the timing of the health effects with the timing of the mom's labor supply effects. This is something that I should do.
Usually when kids go to the nursery the first time.
So it could be concentrated right after. So if they started a little later, perhaps there's a spike in. Okay, I have to check.
I wonder actually if total number of days would make a difference.
let me, yeah.
So kind of agree. But
I'm
then
gonna have
actually
to-
maybe in terms of the total duration, you will find exactly the opposite.
Yeah. Okay, yeah, that's a good point. So I can check that very easily. Okay, let me just write down a couple of things before I forget. Yeah. Okay. Thanks. Okay, so the third channel from the literature was this family process channel. So our parents more relaxed when they get the benefit. So I analyzed parental separation patterns from the labor force survey data, and I do find that eligible mothers were less likely to separate from their partner in the first year after birth. The effect is gone by age 2. So it looks like some separations are slightly delayed by receiving the benefit. Again, this would suggest, if anything, positive health effects, so I don't see how this can reconcile my results. So anyway, so these standard channels don't really help me.
If the childcare, so if you go a bit, I think it depends a bit, if you go later to childcare, so it could be that going earlier to childcare.
Actually helps, yeah, could be.
Like,
Yeah. I think I've seen one paper that might be consistent with that.
Clearly how that works.
Yeah, could be. So yeah, that's a good idea of looking at the timing of starting childcare. Okay, so let me show you what I can tell you about these additional oh, did you have more?
You know the reason of the hospitalization of the kid?
The reason for that?
The reason for why they hospitalize.
Yeah, the diagnosis,
okay,
yeah.
but not the severity of the case.
I know if the child dies or not, if it was an emergency hospitalization or not, and how long the kid stayed in the hospital.
Depending on the emergency.
I haven't looked at the.
Emergency because it could be related to what Raul was saying, that I have this money, I decide to lose 1 day of work, I want to be cautious and I stay in the hospital with the kid.
Yeah.
So it might be related with if you don't see a much, because if there is a very severe case, you will see that both mom will take care of it.
So I could look at diagnoses that are more severe versus kind of not so.
If the less severe, you see that the intensified hospitalization is just mom that now are
Worried moms with too much time. No?
mom gets more cautious.
Yeah, thanks. I couldn't.
When do they get the income?
When? So the July moms got the income in November. So 4 or 5 months after having the baby. Yeah.
So all these income effects would presumably happen after November.
I mean, but they anticipated that they would get it, so it's hard to know how
But you
much.
could still test for that, couldn't you?
Whether the effects show up before or after. I mean, from the timing, it looks like they show up after 6
Immediately,
months or even later than that. So it's not.
Okay.
So it's definitely after they actually get the money. Yeah. But they would. Well, yeah. I'm not going to speculate anymore. Okay. So parental unhealthy or risky behaviors. I analyzed household expenditures on anything bad that I could come up with. So alcohol, tobacco, drugs, transportation, lotteries, gambling, betting. I really find no significant effects there. But again, this household budget survey, because I want to focus on births very close to the threshold, precision is low, so I cannot really confirm or reject that there is an effect. So, okay, what I can test with precision is whether there was an increase in subsequent fertility, so whether the families who got the money have the next child earlier. So I analyzed subsequent fertility with birth certificate data, and I can rule this out. So eligible mothers are no more likely to have another child in the following 2, 4, or 6 years. So I can basically, rule out this channel because these are well-estimated zeros. And then finally, there's the story of higher healthcare utilization. So how can I test for this? So in the expenditure survey, I can look at whether households are buying private health insurance or have higher health-related expenditures. I can't really show that, but again, low precision. So if you know of any other sources where I can see,
That would be private spending.
private, yeah, private.
I mean, using like I don't know, you need the doctor, not like National Health Survey.
Yes, I looked at the National Health Survey as well. But again, if I focus on children born very close to the threshold, I have very few observations, and it's mush. It's like an imprecisely estimated nothing. Yeah. So yeah. Okay. So I don't really have a lot. So all I have at this point is the effect on mother's labor supply and the increase in hospitalizations due to observation and testing. This kind of suggests to me an increase in the increasing hospitalizations could be related to an increase in either detection, testing, or treatment. driven by perhaps maternal time or attention, and perhaps linked to their later return to the labor force. But I would like to have stronger evidence to support this channel. Perhaps looking at the timing of maternal labor supply compared with the timing of the health effects would help. But if you have other ideas, I'll be happy to hear them. So to conclude, so I looked at the health effects of this cash transfer right after birth. I find no significant effect on neonatal, infant, or child mortality. But I do find that children whose mothers were eligible had higher hospitalization rates in the months and years following benefit receipt. I explore a range of channels, and what I conclude is that the child benefit did not seem to improve the health of eligible children, at least as far as I can see in the hospital data. It did increase their healthcare utilization. In terms of next steps, what I'd like to get is access to primary healthcare data so I can say more, not just about hospital stays, but also about other kinds of health problems which may not lead to a hospitalization. That's it.